All right, Ninja Nerds, in this video we're going to talk about the glossopharyngeal nerve or cranial nerve 9. So like always, let's go ahead and talk about what? The origin of the nerve, the course of the nerve, the structures supplied by the nerve, and certain clinical correlations of the nerve along the way. All right, so first off, glossopharyngeal nerve or cranial nerve 9, where are we going to find this? We're going to find a lot of different nuclei for this nerve located within inside of the actual brainstem, particularly within the medulla. So let's go ahead and talk about each different part of this nerve. So if you guys have already watched the video on the facial nerve, we're not going to really spend a time going over explaining all of these different types of fibers because it would just take too much time. If you guys have already seen that, you guys will be caught up because what we're going to talk about is we're going to talk about SVE fibers. We're going to talk about, actually I keep it all one color, but we'll go through the different fibers in different colors. We're going to talk about SVE fibers, Gsa fibers, GVE fibers, and Gva fibers, and we'll talk about one more, which is SVA fibers. The glossopharyngeal nerve has all of these different types of fibers. So let's go through each one of these one by one. Okay, and if you guys remember, SVA fibers is going to be primarily for the taste. SVE fibers is for those that are going to be a part of the pharyngeal arches. I'll write this up here because this is relevant. The glossopharyngeal nerve supplies what pharyngeal arch? I need you to remember the third pharyngeal arch. So this SVE is going to be for the third pharyngeal arch. Because if you remember, the first pharyngeal arch was supplied by the trigeminal nerve, the second pharyngeal arch was supplied by the facial nerve, and the third pharyngeal arch is going to be supplied by the glossopharyngeal nerve. So let's go ahead and start first with the SVA fibers, which are the taste fibers. Okay, so the taste of the glossopharyngeal nerve, where is it going to be coming from? It's going to be coming from the tongue, right? So you know in the tongue here, we're going to have the tongue here. So if you can see here, here's the orbit, here's the anterior cranial fossa, the pterygopalatine fossa, the big old nose, the mouth, so the oral cavity here, and they're going to be coming down into the actual larynx here, and you're going to have parts of the pharynx and the esophagus. So we're seeing parts of that. Specifically, if I were to kind of put like a dividing line here in the tongue, so this is the tongue here. Let's say I put kind of like a dividing line like this. I come like this, and I come down the tongue like that, right? I'm going to shade this in here in this nice reddish color. This right here, right behind the sulcus terminalis that I'm shading in red, this is going to be the posterior 1/3 of the tongue. So the posterior 1/3 of the tongue is going to be supplied by the glossopharyngeal nerve. Now exactly what type of fibers again? Let's do these fibers let's do them in this brown color here. So these fibers here, they're going to be picking up taste. From what type of papilla would be there? You know there's what's called the fungiform papilla and the circumvallate or the vallate papilla. So what two types of papilla are going to be found here? The fungiform, excuse me, and also the vallate papilla. So you're going to be picking up taste from the posterior 1/3 of the tongue, from the fungiform papilla and the vallate papilla. Now look what happens to these fibers. These SVA fibers, or these taste fibers, are going to be moving backwards, right? Now some of these fibers can go in two different directions. We're going to talk about the one main direction here. So the main direction that they're going to go, these taste fibers, is they're going to come to a special ganglion that is located right outside of the actual cranial cavity, right? So right outside of the cranial cavity, there's going to be a special little ganglia. So what is this ganglia here called? This ganglia is actually called the inferior ganglion of the glossopharyngeal nerve. But you know they also like to give things other names. So we can call this what? We can call this ganglion the inferior ganglion. So we can call it the inferior ganglion. Or they always like to give names for other things to make it more complicated, right? You can also call it the Petrosal ganglion. So you can also call this the Petrosal ganglion. What happens is these SVA fibers come to they bring the taste from the posterior 1/3 of the tongue. They synapse on this inferior ganglion, right? So the peripheral process is here. The central processes are going to come in here. And they're going to move through a special structure within the actual skull. What is this hole right here called? This hole here is called the Jugular Foramen. So what is this hole right here called? This hole is called the Jugular Foramen. Okay. So these SVA fibers come up through the Jugular Foramen, and where are they going to go? these SVA fibers are going to go to a specialized nucleus located within the medulla. What is that nucleus called? It's going to go right to this sucker right here. This bad boy right here is called the nucleus of tractus solitarius. So what is this guy here called? I'm going to denote it as NTS. NTS stands for nucleus of tractus solitarius. These SVA fibers are going to go to the nucleus of tractus solitarius. All right, sweet. Let's go to the next guy. Let's go to the next one, SVE. Now, thankfully, this is not that bad of a one. SVE is going to supply the third pharyngeal arch. Thankfully, and ironically, and weirdly, there's only one muscle that is supplied by the glossopharyngeal nerve that was derived from the third pharyngeal arch, and that muscle is called the Stylopharyngeus. Let's follow this one in black. So this guy's going to come, and you know there's actually these sets of nuclei located here within the medulla. There's a specialized nucleus here, and I'm going to denote it here with NA. And NA is basically symbolizing that this is called the nucleus ambiguus. So it's called the nucleus ambiguus. These nerves are going to give off some rootlets, right? And these rootlets are going to move out, right? And they're going to move through this hole in the skull called the jugular foramen. They're going to pass through two different types of ganglion. We'll talk about another ganglion that's kind of like right over here called the superior ganglion, which is just basically a detachment of the inferior ganglion. And it basically picks up some Gsa fibers. We'll talk about that next. But this guy's going to be moving right here, right? He's going to pass through the inferior ganglion, pass through the superior ganglion, pass through the inferior ganglion, and look what happens to this bad boy. He comes over here, and he supplies a special muscle of the soft palate. Okay, there's a special muscle that is around the soft palate area, and here he is. So you know most of the muscles of the palate and even the pharynx are supplied by the vagus nerve, right, via the pharyngeal plexus. But what happens is one of the muscles is supplied by the glossopharyngeal nerve. And if you even remember, we talked about the trigeminal nerve. He also supplied what's called the tensor veli palatini. That's another part of them. But again, this one is only going to be going to, the glossopharyngeal nerve is going to a special muscle here. And this muscle here is called the Stylopharyngeus. And all the Stylopharyngeus does is whenever this muscle contracts, it pulls the pharynx upwards. So it pulls the pharynx upwards during the actual chewing process to prevent any food from coming up into this area, right? Coming up into the nasopharynx. So he's a really cool muscle there. Okay, so he's involved in the basically some of the deglutition response, the swallowing response, right? Chewing and swallowing. All right, so that's the Stylopharyngeus, and that is the only muscle that the glossopharyngeal nerve is supplying. And again, what arch is it coming from? The third pharyngeal arch. All right, sweet deal. Next, Gsa fibers. The Gsa fibers are really, really simple. Okay, the Gsa fibers are actually going to be coming through there's two parts actually. Let me show you guys here from this bottom part here. So you know we have the auricle or the pinna, so the skin around the ear, it's going to pick up some actual touch pain temperature fibers from that area. It's also going to pick up some actual touch pain temperature sensations from the external acoustic meatus. It's also going to pick up some touch pain temperature from the tympanic cavity. And you know what membrane's right here on the inner surface here? Let's say that I actually put it like this now. It supplies the inner surface of the tympanic membrane. So it supplies the inner surface of the tympanic membrane. It supplies the tympanic cavity. Ooh, and it even gives off another one to the pharyngotympanic tube. So it gives off a structure here to the pharyngotympanic tube. So these Gsa fibers are supplying the skin of the ear. They're supplying the external acoustic meatus. They're supplying the inner part of the tympanic membrane. They're supplying the tympanic cavity and even the pharyngotympanic tube. And look what this sucker is doing. It's moving right up here. And remember I told you there was a ganglion, right? Well, this guy has a ganglion located within the superior ganglion, right? So this is called the superior ganglion of the cranial nerve 9 or glossopharyngeal nerve. So I could call this the superior ganglion of cranial nerve 9. And this is the inferior ganglion of cranial nerve 9. And the reason why I'm being very specific is that the vagus nerve also has a superior ganglion and an inferior ganglion. So I want to make sure that I'm very, very specific in saying that the superior ganglion for cranial nerve 9 and the inferior ganglion for cranial nerve 9 or the Petrosal ganglion. So again, these Gsa fibers are coming from the auricle, the external acoustic meatus, the inner part of the tympanic membrane, the tympanic cavity, the pharyngotympanic tube, and bringing these suckers upwards. Then from here, from that superior ganglion, it gives off its central process. And the central process moves through the jugular foramen. As it comes out of the jugular foramen, it gives off a kind of like a little recurrent branch over here too that supplies the tissue in this area. What tissue would actually be lining the bone? If I were to do it here in this orange, let me grab this orange here quick. Let's say I put this orange tissue here, and it's supposed to represent a specific type of tissue right here. Let's say that that's your Dura Mater. That's your Dura Mater. So this right here, that little orangish area is called the Dura Mater. These Gsa fibers can pick up pain within the Dura Mater. You know the Dura Mater is actually made up of two layers, the periosteal layer and the meningeal layer. It's going to supply the Dura Mater and pick up pain. So maybe certain types of pain in that area. And these Gsa fibers will come into where? They'll come into the medulla, and they'll give off their central process to a specific structure. What is that structure? Well, since it's touch, pain, and temperature fibers, it's going to go to the spinal nucleus of the trigeminal system. So what is this nucleus here called? This nucleus is called the spinal nucleus of cranial nerve 5, or the trigeminal nerve, right? Sweet deal. So again, what is he supplying? Auricle or pinna, external acoustic meatus, tympanic membrane, tympanic cavity, pharyngotympanic tube, and it gives off a little recurrent branch to supply the Dura Mater, and then goes into the spinal nucleus of the trigeminal nerve. Okay, so that's GSA. So what have we gotten so far? We've done SVA, we've done SVE, we've done GSA. Now let's do the GVE. We obviously got to do the hard one now. Okay, so this guy's not too bad. It's just a little bit of a complicated route here. Okay, so now, you know there's another nucleus located here within the medulla and kind of like within the lower pons kind of area? This nucleus is called the inferior salivatory nucleus. You guys probably remember another nucleus over here, right? That was actually important for the facial nerve. What was this nucleus here called? This was called the superior salivatory nucleus. Do not get these two confused. So the superior salivatory nucleus was going to the facial nerve. The inferior salivatory nucleus is going to be for the glossopharyngeal nerve. So now, these fibers, what kind of fibers are these? These are parasympathetic fibers. These are parasympathetic fibers. Let's write that up here. So the GVE fibers are going to be parasympathetic fibers. This is important, okay? So these, just like the superior salivatory nucleus was giving off parasympathetic fibers for the facial nerve, these guys are going to come out of the medulla, and they're going to go through this hole here. What is this hole here called? It's called the jugular foramen. It's going to come out of the jugular foramen, and it's going to go and make a little weird course here, okay? It's going to course here to a part of the ear, the tympanic cavity, right? So here I'm drawing a view of the tympanic cavity as you're kind of looking at this wall. What is this wall right here? This is the medial wall, okay? This is the medial wall. This right here is the posterior wall. This over here is the anterior wall. This right here is the floor of the tympanic cavity. And if you imagine right here would be the lateral wall. So imagine right here where the tympanic membrane, where my hand is, that would be where the lateral wall is. So we're looking at it from a different view, taking the lateral wall off, and we're looking at it like that now, okay? Now look what happens. This sucker right here, this son of a gun, he runs through a tiny little hole on the floor of the tympanic cavity. So he runs through the floor of the tympanic cavity through a tiny little hole called the Tympanic Canaliculus. What is this hole here called? On the floor of the tympanic cavity is called the Tympanic Canaliculus. It moves through that hole. What would you call this guy here that's actually coming up here, coming up through the Tympanic Canaliculus? We actually call this the tympanic nerve, or the tympanic branch of the glossopharyngeal nerve. So you can call it the tympanic nerve, or if you want, you can call it the tympanic branch of the glossopharyngeal nerve. It does something really weird, and it gives off fibers onto this promontory right here. So it gives off these little plexus right here that goes to this promontory. You know, this is the promontory of the tympanic cavity. This right here is the oval window. This is the round window. This is the facial canal, the bony canal where the facial nerve fibers run through, right? We talked about that and why it's important with Bell's palsy. Okay, this is called, when it forms here, it forms the tympanic plexus. But you might be like, Zach, I thought the tympanic plexus is kind of like a mixture of different types of nerves. It is. So now I got to take you down here and show you something else. So let's do this one in this pinkish color here. All right. Actually, no, let's do it in the purple. Let's do it in purple. Okay. There's something really interesting here. And if you guys remember, we talked about a little bit with the facial nerve. There's these little nuclei here located within the lateral gray horn of the spinal cord. So this is the cross section of the spinal cord, right? You know, you can call it the lateral gray horn, or you can even call it the intermediate medial gray horn, right? The intermediate medial gray horn. Either way, these fibers, these cell bodies of the preganglionic motor neurons of the sympathetic nervous system will move out here, and they'll come out to a ganglia. You know, this is what's called the superior cervical ganglion. And from the superior cervical ganglion, these postganglionic sympathetic motor neurons come out, and what they do is they wrap around the internal carotid artery, like a plexus basically, right? This carotid plexus. Why am I mentioning this? Because some of these fibers, before they move up through a hole in the skull called the foramen lacerum, they give off some fibers here, these sympathetic fibers. And these sympathetic fibers will actually come over here onto the promontory, and it'll give off branches here to the promontory. So now what do we have here? What is this whole structure here called that's mixed with the sympathetic nerves and the parasympathetic nerves? This whole structure right here where the promontory is called the tympanic plexus. Now what's important to this is that some of the fibers, some of these actual parasympathetic fibers will come out. And it might gain a little bit of these it might gain a little bit of these sympathetic fibers. Just going to let you know that we're not going to follow it all the way. I just want you to know that some of the sympathetic fibers coming from this plexus from the internal carotid artery can actually follow with the parasympathetic nerve. But you know, we don't call this a parasympathetic nerve. We give it a special name. It's got to be a special name. We call this nerve the lesser petrosal nerve. So this lesser petrosal nerve is going to come out of the tympanic plexus, and it's going to actually gain a little bit of the sympathetic fibers. But that's not important, because what's going to happen is this nerve is going to move upwards. So it's going to move upwards towards the middle cranial fossa. As it moves upwards, it moves through this little hiatus here, this little hiatus within the, basically this part here where the middle cranial fossa is. It moves through this tiny little hiatus, and that hiatus is called the hiatus of, I'm not going to write the whole thing, I'm going to put LPN for lesser petrosal nerve. So it moves through the hiatus of the lesser petrosal nerve. Then it moves within the middle cranial fossa. As it moves through the middle cranial fossa, it comes out of the middle cranial fossa and moves through this hole right here called the foramen ovale. So what is this hole here called? This hole right here is called the foramen ovale. Why am I mentioning this? Because you know there's another nerve that runs through there. We've talked about this one. What was that other nerve? Remember there was the trigeminal ganglion right here? And the trigeminal ganglion gave off V1, V2, and V3. And V3 was the mandibular branch of the trigeminal nerve, or the mandibular nerve that moved through the foramen ovale. This will actually move nearby. This green nerve here, this lesser petrosal nerve, will move from that anteriorly. It'll move from that anteriorly, and what happens is it has a communication with some nerves running within this pterygoid canal. Do you guys remember what nerves are running in the pterygoid canal? For the sake of it, I'm going to draw them in different colors so that they're not confusing here. I'm going to put here a pink one. Let's say that that pink one is the greater petrosal nerve. And let's say here I put in purple, just a part of this guy here. This one actually here. I can come up with it. What was that one? That was called the deep petrosal nerve. That was the Vidian nerve, the one that's running within the pterygoid canal. This develops communications. So this lesser petrosal nerve right here, this is the lesser petrosal nerve. We always got to give these things crazy names, right? Greater petrosal nerve, deep petrosal nerve, lesser petrosal nerve. These will actually have communicating branches with the nerve of the pterygoid canal, or the Vidian nerve. Okay. Then from there, where is it going to go? It's going to continue anteriorly. And it's going to go to a ganglion. So it's going to go here to a ganglia. What is this ganglia here called? It's called the Otic Ganglion. The Otic Ganglion. And then from this Otic Ganglion, this contains the cell bodies of the parasympathetic postganglionic motor neurons. And then what will happen? These will come over here to a gland. Now this gland is not in the actual oral cavity, so don't get that twisted. It's actually located outside here. Okay, so that's actually located on the outside of the skin, right underneath the skin, above the masseter muscle, there's the parotid gland. That guy right there, this lesser petrosal nerve is going to supply the parotid gland. And then what is the parotid gland going to do? The parotid gland is going to produce saliva, and that saliva can move through a special duct system, right? The parotid duct. And then that parotid duct is going to release that saliva into the oral cavity. Okay. So again, what is this glandular structure here called? It's called the, right up above it, parotid gland. All right, sweet deal. That's the Gba fibers. Okay, we're moving here. Let's do the Gva. Okay, Gva fibers are general visceral afferent fibers. They're going to be picking up visceral sensations, but from where? Okay, let's do this one in pink now. Okay, let's come back over here. Okay, these guys, actually no, we're not going to do this one in pink because it's going to get too messed up. Let's do this one in this blue color here. Okay, let's do it in blue. Okay, a couple areas within this pharynx and oral cavity that are supplied by the glossopharyngeal nerve. Okay, it's primarily sensory. Okay, you know there's the parts of the pharynx? You know there's the parts of the pharynx here? You know this is called the oropharynx and laryngopharynx. That's supplied by the glossopharyngeal nerve. So it gives touch, pain, temperature fibers to the pharynx. Particularly though, what parts of the pharynx? You know you have what's called the oropharynx and even the laryngopharynx. It doesn't really get very much from the, it doesn't supply much of the nasopharynx because that's going to be primarily the trigeminal nerve, right? So the trigeminal nerve supplies most of the nasopharynx, whereas the glossopharyngeal nerve gives touch, pain, temperature fibers primarily for the visceral sensations to the oropharynx and the laryngopharynx. What else is it going to supply? You know there's this area over here where the posterior 1/3 of the tongue is. So in the posterior 1/3 of the tongue, we have to have touch, pain, temperature fibers there. So we have these Gva fibers that are going to be touch, pain, temperature fibers within the posterior 1/3 of the tongue. Even, you know there's the tonsils, like the palatine tonsils and the lingual tonsils. There's a little bit of skin, a little bit of tissue, a little bit of epithelial tissue surrounding that. So from the epithelial tissue surrounding these tonsils, like the lingual tonsils and the palatine tonsils, these guys are going to have some actual fibers picking up there too. So these Gva fibers there. What else? Even the touch, pain, temperature fibers of the visceral sensations from the soft palate and even the uvula area, right? That's also going to have these Gva fibers. So what do we have so far? We have fibers from the soft palate, a little bit of the uvula, the posterior 1/3 of the tongue, the tonsils, the oropharynx, the laryngopharynx. Ooh, these guys are moving here, right? So again, what areas are supplied? Oropharynx, laryngopharynx, posterior 1/3 of the tongue, lingual tonsils, palatine tonsils, soft palate, and a little bit of the uvula. These are all moving through the Gva fibers, right? Now, these Gva fibers are very special too, because they're going to come and they're going to have another ganglia, but their ganglia is located within the inferior ganglion, or what is that called? The Petrosal ganglion, okay? Now, this guy's going to go in, right? But before we actually take this guy into the central nervous system, what's going to happen? You know he has other branches here too? I should actually bring this one down here. He has other Gva fibers, and these are going to be supplying a specific area. You know there's what's called the carotid sinus and the carotid bodies. So let's draw these suckers here in green. If you remember, we had the glomus cell, right? We had the glomus cells right here. These were the carotid bodies. They were basically picking up what? They were picking up the chemo. These were chemoreceptors, right? Your peripheral chemoreceptors. So they were picking up what? The partial pressure of oxygen, the partial pressure of CO2, and the arterial pH. The arterial pH, but specifically from metabolic acids. So again, these chemoreceptors, your peripheral chemoreceptors, are picking up arterial pH due to metabolic acids. They were picking up the partial pressure of oxygen within the blood. They were picking up the partial pressure of CO2 within the arterial blood, right? And who was going to be sending those action potentials back to the actual medulla? It was the glossopharyngeal nerve. So he has branches. They're going to be supplying those. Remember those glomus cells? The glomus cells that were basically having those different types of channels that we talked about within the respiratory system. That's going to be having these afferent, these Gba fibers that are picking up those sensations from these chemoreceptors. But also, if you guys remember, we even had these carotid sinus. These were your baroreceptors. So what are these right here? So we don't confuse this. This was our baroreceptors. And this was in what's called the carotid sinus. These over here, these green little dudes, these are actually going to be called what? These green little dudes here are called your chemoreceptors, particularly the peripheral, right? And these guys are going to be located within the carotid body. Somebody told me once the good way to kind of remember the difference between these two is remember sinus and pressure. So sinus pressure. So it kind of helps you to remember, okay, the sinus is for pressure. So this is picking up changes within blood pressure. So decreases in blood pressure and increases in blood pressure. And then by result, you just have to remember that the chemoreceptors are within the carotid body, and those are picking up CO2, O2, and arterial pH. All right, sweet. And those are coming up through the Gba fibers, right? So they're taking the information upwards. This is taking the information from the oropharynx, laryngopharynx, posterior one-third of the tongue, tonsils, soft palate, and bringing these fibers inward to this Petrosal ganglion, or inferior ganglion of cranial nerve 9. Then these central processes are moving where? They're moving up through the jugular foramen. They move up through the jugular foramen, and then they go into the where? They go into the medulla, and from the medulla they'll go and supply they'll go to a specific nucleus. What is this nucleus right here called? Okay. So it's going to be taking these Gba fibers into two different areas, actually. Two different areas. That, some literature says that it actually takes it to one area. Other literature says it takes it to two areas, right? For right now, we're going to say that the main one, and we're going to star it. The main one that the books say now is that it goes to the nucleus of tractus solitarius. But some literature will say that it also goes to another structure called the dorsal nucleus of vagus, okay? Now, primarily, the chemoreceptors and the baroreceptors are primarily going to the nucleus of tractus solitarius. But they do believe that maybe some of those visceral sensations from the oropharynx, laryngopharynx, tonsils, posterior one-third of the tongue, soft palate, some of them might go to the dorsal nucleus of vagus and the nucleus of tractus solitarius. Okay, so just so we're very clear with that, dorsal nucleus of vagus and nucleus of tractus solitarius. However, literature supporting most of the nucleus of tractus solitarius, receiving the Gba fibers. All right, sweet. We have covered all of these fibers then. We've talked about the Gve fibers, we talked about the Gva fibers. Now let's go ahead and apply clinical correlations. We're not going to spend a significant amount of time about this, and the reason why is if the glossopharyngeal nerve is affected, there's other nerves that run in this cavity with it, and I'm just going to highlight those. It would also be another nerve that could actually be running in this area is cranial nerve 10 and cranial nerve 11. So the vagus nerve and the accessory nerve are also running through the jugular foramen. So rarely is the glossopharyngeal nerve ever isolated in some type of injury, very rarely. Okay, there is certain situations, but usually if the glossopharyngeal nerve is affected, so is the vagus and so is the accessory. So if you could imagine the different types of symptoms that could come from a patient if all of these nerves were damaged. I mean, think about it. The vagus nerve is controlling swallowing, so they might have dysphagia. It controls voice production, so they might have dysphonia, trouble being able to produce speech. They might even have vocal cord paralysis. If the accessory nerve is damaged, they might have sternocleidomastoid and trapezius weakness. What else? They might even have, if the glossopharyngeal nerve is damaged, they might have neuropathic pain. So neuropathic pain primarily within like the posterior 1/3 of the tongue, or the entire pharynx, right? Or even that soft palate area, or maybe even the ear, or the tympanic cavity. So a lot of different things can come to these people. Also, what else? They might have loss of taste. So they might have loss of taste within the posterior 1/3 of the tongue if the glossopharyngeal nerve is damaged. So like I said, in general, whenever the glossopharyngeal nerve is damaged, it's usually also going to be associated with cranial nerve 10 and cranial nerve 11. Now, what could be certain causes of this? There could be many. I mean, we could go through and talk about some of them. So for example, if you had a tumor, like some type of meningioma that developed here, like a meningioma that developed from the Dura Mater that compressed these nerves, that could actually cause it. So some type of meningioma within the posterior cranial fossa. Meningioma. Or, you know, there also could be metastatic lesions. You know, there's different types of tumors like chordomas or cholestestomas. Or, you know, in certain types of situations in which there's breast cancer or maybe even bronchial cancer. So if there's some type of bronchial cancer or breast cancer, these can spread. They're metastatic lesions that can actually spread. And there's many other different types of, you know, even lymphoma can also spread. And where can these guys go? They can actually develop different types of metastatic lesions at the base of the skull. And these metastatic lesions that could develop at the base of the skull could also compress the glossopharyngeal nerve. So again, there could be meningiomas within the posterior cranial fossa. There could be certain types of metastatic lesions at the base of the skull, like chordomas or cholestestomas or bronchial cancer or breast cancer, lymphoma, many different types of situations there. Another one that could actually develop here, ooh, you know there's a sinus, the mastoid sinus? This is another one. There's a sinus here. Let's actually do this one in black. You actually have, it's actually behind the actual tympanic cavity. So let's say I kind of draw it like this. Here's the mastoid sinus like this. I do it like this right here. Here's your mastoid sinus. Let's say that you had some type of infection within this mastoid sinus. So there was an infection developing here. So some type of infection developed within the mastoid sinus and it started extending. It starts extending upwards into this area where the glossopharyngeal nerve is, right? Or where these other cranial nerves are, and it actually can compress the nerve. So what are some of the reasons here? It could be due to a chordoma, cholesteoma, bronchial cancer, breast cancer, that due to metastatic lesions at the base of the skull. It could be due to a mastoid sinus infection that spread upwards and extended. It could be due to a meningioma within the posterior cranial fossa. Another one is it also runs near this area here. You know there's also another situation here called a paraganglioma, a carotid body tumor. So these guys, they can actually become tumorous. I don't even know if that's a word, tumorous. They can actually develop tumors here. And it's called a carotid body tumor. So let's say that you develop a carotid body tumor here. You know what else they call it? They call it a paraganglioma. So let's say that you develop a situation here called a paraganglioma. These are very rare tumors. They're kind of like neuroendocrine tumors that can develop. But if they actually compress the glossopharyngeal nerve, that could also cause different types of problems there. Either way, we get the point that there could be what? Meningiomas within the posterior cranial fossa, could be metastatic lesions at the base of the skull like chordomas, cholestestomas, bronchial cancer, breast cancer. Could be due to a mastoid sinus infection that spread, or it could be due to a paraganglioma. It even could be due to autoimmune diseases too that could actually cause this problem. All right, engineers, in this video we covered pretty much everything that we can about the glossopharyngeal nerve. I hope it all made sense. I hope you guys really did enjoy it. If you guys did, please hit the like button, comment down in the comment section, and please subscribe. All right, engineers, until next time.